Thank you very much. So we've got two very engaging presentations after lunch, setting, I think, continuing the high standard we had before lunch. So we've got an opportunity for questions and comments. Cindy.
Thanks very much. Chris, as our token lawyer, I'm going to put you on the hot seat a little bit in terms of trying to give us some insight into others with your profession. So, you know, we have, for example, Rebecca's research that showed that 28% of individuals didn't understand after the first pass with a form that was at the 6th grade level that was read out loud to them. We know that, you know, a lot of the concepts are difficult. We can put it on paper even more clearly. We can, you know, change our processes. My question is, why aren't lawyers leading the charge? Why is it that they don't say, of course, having somebody sign an understandable form is not going to provide us with any legal protection? And how do we get them over that hump to realize that even if their only goal is to protect against lawsuits and malpractice, that this is what they should be arguing for?
Well, it's a great question. I really think it comes down to two things. One, we have to give them the will to do it, the understanding, you know, the knowledge that's out there, but also the skills to do it. You know, so with the will idea, this is where I think our advocacy can come into play. I don't think a lot of folks really, particularly lawyers, understand how health literacy principles or just literacy principles in general in terms of, otherwise we would not have the 2,200-page Affordable Care Act, and we wouldn't have all of you know, our credit card agreements that are typically written at a 12th grade level. They just don't understand what they're creating. And I think part of this is a law school problem. And I go around kind of, you know, advocating for change and trying to get lawyers on board with what I'm suggesting. But part of this is that drafting, or, you know, this is what I would call drafting as opposed to writing a brief, and, you know, that's to a judge or whatever. But we have a lot of studies that suggest what judges want. And they generally want, you know, because, not that they can't understand the terms, but they generally want things that are clear and understandable so that way they can go home or golf or whatever they want to do. But there's not a lot of information on drafting. You know, so we have a lot for brief writing, but not a lot on drafting and the folks that actually read and use these things. So I think part of it is just lawyers don't understand how their users think. So this whole UX, usability design, is a big thing that I think it's been going on. Plain language, the plain language movement has been around for a while, and I'm part of a lot of organizations, but it's slow going, much like health literacy. You know, it's more of a generational change, but we do the best we can. So that's why I was suggesting that probably the best way to do it is with the, instead of the incentive, it's with the stick of litigation. You know, after somebody's been sued and a court suggests that this is not understandable, you need to change your forms. Well, we're going to get more action that way, because that's what we're taught to be concerned about as lawyers, is what courts say, not what people say, unfortunately. And then from the skills, again, because we don't teach a lot of drafting, I don't think lawyers truly appreciate how to do this. They know how to put legal requirements in there just by taking, you know, other things that have come before you. That's what we do. We take, you know, this form worked, it was litigated, let's just take that exact form, you know, because it's been litigated. But not thinking about what is the best way to convey that information. You know, so that is the problem. I think it's a two-pronged problem of giving people the desire to do it, but also the skills, teaching them the skills to create better documents.
Thank you. Just a couple quick things. A very small note, Chris, on your ideal scenario.
Could you come closer to the microphone?
Sure. On the
and
ideal,
actually, I'm remiss by not reminding people to identify themselves. So let's start with you. So
this is true. So I'm Andrew Pleasant. I work at a nonprofit called Candy and Wrench Institute based in Tucson, Arizona, but we work all around the world. First, just a suggestion. On the ideal scenario that you laid out on that slide, I would, given especially the input this morning, think about moving that informed consent moment prior to the appointment, because you're also potentially, wasting time and money if someone says no at that point in time, plus the pressure of facing the procedure immediately. So I'd rethink that. And then a question, I completely concur with this notion of outcomes being part of the discussion. And when I do informed consent statements, especially in community settings, I'm always required to include a statement of benefits as well as a statement of potential risks. So to me, the outcomes are benefits, but you're largely talking about a very clinical setting, and I am not a trained medical provider. So I wonder if the resistance there isn't that people are very hesitant and in fact trained not to predict outcomes, but to describe procedures, because it creates another liability problem. I don't know, I'm asking.
Well, I'll address the form, or I think you're absolutely right. Just in the process of thinking about it today, I think we can give the form, and we should give the form earlier, and a chance, and perhaps even creating, with some of the offices having 24-hour nurse lines or whatever it might be better to give it earlier, and maybe along with the patient education forms, or after they do a tutorial, here's the form, bring it back in when you come with, to your appointment or something after you've done the prep. And if you have any questions before that, we should talk about it. I mean, it'd be nice to have them come in before they prep and do all that, but I don't know if that's necessarily practical. But I think you're absolutely right. Instead of giving it to them at the visit, give it to them earlier, so that way they can look at it and look up any terms and have any questions. I think that so the process is definitely something that can be certainly refined. Absolutely. So I'll let Rebecca talk about the outcomes.
Yeah, and before I answer your question, I just want to make sure that I understand. So you said that you do informed consent all the time, but you're not a physician. So what do you do informed consent for?
Oh, I actually do something we're not talking about today, community-based research. So I work in communities at clinical settings a lot with clinical providers, but it's a much longer-term effort focused on prevention. We'd rather keep people healthy than wait for them to get sick.
Right. Well, I will say this is my own personal perception, and again, this is what my entire research is based on, so I feel very passionate about it. I actually think that there's more liability if you actually don't know who the person is. And again, on the backside, as a geriatrician and palliative care physician who's called to the ICU for family meetings, the problems and the issues and the legal problems come when people do not understand the person, what they wanted, what was important to them, and they just focus on the procedures. So, and I would love to hear your perspective on that. We sort of put these things into the law, the risks, benefits, and alternatives. But again, for me, anything in advanced care planning, anything in informed consent, if we don't take what's important to the person and translate that, help them translate that into the care that they want or don't want, I actually think that that's a big problem. And I actually think, again, on the backside, that's where the legal problems come in.
Michael Valaire with Institute for Healthcare Advancement. First of all, for Chris, both great presentations, by the way. Thank you. Chris, we, along with a lot of other organizations, teach these principles to people who are creating forms, who are writing patient education materials, and we give them all of the basics on how to use white space and plain language and graphics and limit messages and all of those principles that at least remove barriers to comprehension. Nothing will ever guarantee comprehension, but we can at least take out as many barriers as we can see. One of the places where these things hit the pothole and just stop and dead end is, unfortunately, as you know, their company's attorneys. Well, you have to put this in. This all has to be in caps. This is 800 words that must fit in the lower right corner of this particular document. And there's obviously a power imbalance there in many organizations where the patient educator, the person who's writing these forms and actually does a great job in creating these documents, then it goes to legal and there's the end of it. What sort of advice, there's likely no magic bullet, but what is the next best thing to a magic bullet? How can those conversations happen? What sort of approach can these folks who are creating these really great forms use to try and overcome that hard stop there?
Well, that's a very interesting question. That's what I'm presenting on to the FDA tomorrow, actually. And it's a 3-hour presentation, so I cannot possibly It's broken up. It's broken up, by the way. I cannot possibly do that question justice, but there are a lot of things to do, and that is and you hit the nail on the head. And that's what I mostly do is advocate for plain language, in every organization, if it's government or business or healthcare or law or whatever. So I'm very well used to this, but the way I kind of liken it is, if I were to try to tell Rebecca how to do a colonoscopy, she wouldn't listen to me. I don't know anything about it, and that's exactly what what you're describing here with I think with the folks that are creating these patient education materials, is that it's the imbalance between, well, this person's a lawyer, went to law school, and passed the bar, so they know what they're talking about, but in reality, like I just was talking about, they don't know what they're talking about when it comes to creating an understanding. They know what they're talking about when it comes to protecting the client, but that's where we need to get folks on board and educating them that you can do things. And that's, instead of just speaking about it, that's why I wanted to create a forum and show folks, maybe we can advocate that you can still get the job done in a way that comports with these health literacy principles. It's not just, it's not just the law's way or the highway is the idea. So that's a longer discussion, but also a longer procedure for it to happen. I mean, I think it starts with trying to find some health literacy lawyers, as I call myself. I might be the only one in the country, or at least the only one that's willing to call myself that in the country. So anyhow, we need to start with that. So we have a lot of health lawyers in the country, people that know everything about HIPAA and the Affordable Care Act, but they're not necessarily the best health literacy lawyers. So we need to teach those folks. And that, I think, is going to pay dividends in the long run, because you'll get some of those folks that can be champions for you. Say, no, I've researched the law in California, or I've researched the law in Michigan, and this is what's required. It's not required to say this particular language. And maybe it is. Maybe it is required to say a particular language in the bottom right-hand corner, and that's okay. But the rest of your document should follow all of the principles we're talking about. We can kind of suit both needs, even though we can't just overturn the law with the flip of a switch, so.
Just to follow up, so I mean, I'd hate to have people try to fight that battle on the attorney's turf, saying that I've researched the law, because obviously they're going to be at the disadvantage. But in terms of starting that conversation, what can they, I mean, just like one or two things that they can actually use to, start to bring everybody toward a middle ground there?
Well, we can start really with a lot of the plain language training, and that's where I think if you bring a lawyer in who understands plain language principles or understands health literacy or something like that, it's equal arguing turf. Then it's okay. Let's explain these things. But the economic benefits of plain language is, the things that really might help. It would be like Rebecca was suggesting, and I suggested in my presentation here, this idea that we're going to protect your client by putting these procedures in place. So it's not just rewriting the form because there's, to help patient understanding, which should be enough for anybody, but it's not going to be enough for some lawyers. But it's also going to protect the client, and that's your goal, right, is to not get them sued. And that's where I think some inroads, I don't know if they're going to be the inroads you want, but at least we'll start with the inroads and start hacking through that forest of uncertainty.
Winston?
Thank you. I'm Winston Wong with Kaiser Permanente and also a member of the Roundtable. So this is for both of you, but principally for Rebecca, because you started off your presentation with the story about this woman whose directives were confused by her family members as well as ultimately her own situation. And it made me think about how you factor in and whether you systematically consider the health literacy capacity of not just the individual, but the family. And is there a way to systematically get that documented, and or whether how that plays out in terms of, even in your case, Chris, is there a way to document that, for example, I have spoken to my family understands the implications of my decision. Is there any role for family health literacy to be part of this solution?
I think that's a really good question, and I think it comes up all the time. If we're thinking about somebody who has dementia, right, it's often somebody making decisions for them. If we're thinking about advanced care planning, we're often talking about surrogate decision makers or these people that will make decisions for someone else. And in terms of what I can tell you what I do is that, and again, this is all part of why discussions are so important, I try to make sure as much as possible that those people are part of the conversation. And again, with the teach back, I don't just do teach back with the patient, I do teach back with the family. So for instance, somebody will say to me, this is what I want, and here are the reasons, and we'll talk about that. And then I will turn to a family member and say, did you just hear what somebody said? And what can you say in your own words what that means to you? And I do document that that person was there. I called them, they were on the phone, we had the conversation. Because I think especially, again, for advanced care planning type things, we do need to document sort of that people understand. And, as, often happens, somebody who goes in, say for a high risk procedure, something may happen. There might be a surrogate or family member who is sort of waiting in the waiting room and decisions have to be made. Did they really understand sort of what was going on? So I think that's sort of a really important point. So I think the teach back and documenting that is sort of an important piece. And I think, was there another piece to that?
Would be more towards Chris, whether that aspect of the patient affirming that they had a conversation with family members, is that any part of a legal document in your
I
perspective?
think it can be, actually, not with this particular form, obviously, since you saw it, but one of the other ones I redrafted recently was a infusion or insulin infusion pump therapy agreement. And that was the idea, was it wasn't always the patient that had to agree to things, so it could sometimes be a caregiver, a family member, or whatever. And so that's kind of what I did, was much like the second document where I had a line through the middle, it was, the patient, if it applied to the patient and the patient could agree, then they would check or initial one side of the document. It was, I, agree to use this insulin pump in this manner. And there's all these different statements, basically. And on the other side were the initial boxes for the, for the caregiver. And that was the idea. So you're getting the mutual consent that way. But it really, that, again, it's just the back end legal way of showing there's a consent. But it's really the conversation, I think, educating, the family members as well. It's not just, here's a form, you need to read this, caregiver, but also the conversation. But I think, yes, we can document that in the legal way. That will help, particularly, like Rebecca was talking about in the end of care, end of life issues, because those are the ones that are going to be suing if somebody dies. So it's probably beneficial from a legal standpoint as well to educate them. So if something goes wrong, they're less likely to sue.
Cindy?
Bernard Dreyer from New York City. I'm a pediatrician, and I work at Bellevue Hospital and NYU. So, Mike, this is directed primarily to Chris. First of all, I loved your revamped consent forms, having just had a colonoscopy myself. I would have appreciated that.
Sorry for your loss.
It was a wonderful experience.
That's too much information.
So I guess my question, it's sort of two questions. One is, in my institution, and actually I'm part of the city hospital system, they won't allow us to have pre-printed forms because they feel that the live creation of the risks and benefits makes the physician really don't ask me to defend it because I think it's wrong, but so that's an issue. But more importantly, there are many, many procedures, and obviously we can't have a pre-printed form for every procedure. So I wonder what your thoughts are about, I hate to use the word template, but template guides that allow people to create a form similar to yours, which is on a question answer-based format, and have you thought about that, and how could that be instituted in medical care?
Well, I haven't thought about it, but let me ask you this question. So my understanding is you can't have a pre-printed form, but you create it for your hospital, or you just the doctors or the physicians have to
forget about my hospital. I'm just focusing on your form. For procedures that are not as common as colonoscopy, where there might not be somebody who's already worked out the detail, how could we assist people live to be able to think about what they should be saying to patients and, or, period?
Well, it might just be the question and answer style of that. This is this is what the procedure is going to entail. This is what the risks are going to be, and have the. But then again, you're relying on the physician or whoever's putting that together to put it together well. So I don't know. I'd have to put some more thought into that. But I mean, that's where the IOM and the AMA and even the individual state organizations could come up with something like that for maybe for most of the procedures, and then some of the other procedures that might be even more rare would be something that would have to be individualized based on circumstance. But that's not always a bad thing if you think there's going to be some major risks with this rare procedure. Well, it might be worth having your legal staff or somebody create one for that, and then should that come up again, then you don't have that issue again. So that might take time, but I have to put some more thought into that.
Lindsay?
My name is Lindsay Robinson. I'm from Northern California. I'm from the California Dental Association. In both great presentations, and Chris, I thank you so much for, you really walk the walk and talk the talk, because they included in our agenda book your empirical research that you've done, and the way you wrote it really reflects your extreme interest in plain language, because it was so easy visually to read and to understand, large font, which I appreciate very much. So again, thank you for that. Actually, Winston asked a question earlier that I was curious about, but I wanted to maybe expand it, my understanding a little bit more in terms of the advanced medical directive, the process by which it starts at the attorney's office, essentially, in talking to an individual or a family, and how that directive gets moves into the clinical care setting. How that works, is that really up to the individual? I mean, how is there any? Okay, I'm very curious.
Passing that off.
Do you have all afternoon? Happy to talk about that. So, bane of my existence. So the thing is, you can get advanced directives from many places. You can get it from your doctor, get it from a nurse, get it from the internet, get it from the lawyer. Case in point, this is my own family study. I've been talking about advanced directives, advanced care planning with my grandmother for years. I actually wrote a paper about my experience with my grandfather and my grandmother. She was recently just hospitalized, and I called my dad. We've had discussions, I'm not kidding, 10 times. And I said, okay, well, where's grandma's advanced directives? Oh, it's totally fine. Don't worry about it. It's with the lawyer. And I said, well, that's great. Does the doctor have a copy? Because the lawyer isn't treating grandma right now in the hospital. So I think a lot of times, I think the lawyers do a good job. I think there are many very dedicated, not always, but I've met many dedicated lawyers who want people's voice to be heard, that actually sit down and have conversations and document them, but then they stay at the lawyer's office or they stay in somebody's file cabinet and they actually don't make it to the doctor's office. And I would say that even with the advent of electronic medical records, this really is sort of like, if somebody could figure this one piece out, and I know there are a lot of companies looking at cloud-based options and things like that, that could really help. I will put in a plug for the American Bar Association's, do you know about this? They have a web app, or not a web app, a phone app, where you can actually upload documents to your phone. And because it isn't cloud-based and it's on your phone, it's actually supposed to be secure. So if the lawyer's doing it, you can be there in the office and upload it onto your phone. But like I said, if we had all afternoon, we'd talk about it more. But there's many lesions there.
And I have another question for Rebecca. In terms of when a physician makes referral to hospice care, is there any kind of criteria that is followed? And I have to share with you my personal experience with my mother, who was diagnosed with a terminal pulmonary disease, and she was ill for a few years. So she lived on the other coast. She came to live with me for the last, as it turns out, the last 6 months of her life, she, the primary care physician that we were using, didn't want to refer her to hospice yet because she described to me, the physician described to me, another patient who lived 18 months, I guess longer. She had exhausted the hospice. There's like a time limit, and then you're not supposed to be there anymore. And she didn't want to refer my mother into hospice care, so we had to actually do a go around to get there. So, do you have any comments you can make about that?
Yes, and I'm happy to talk to you more about it sort of afterwards as well. But we discharge people from hospice all the time, and it's actually a good thing because oftentimes people need that extra level of support, and as soon as they get it, they do better. Studies show that people get palliative care, they live longer. So it's not sort of surprising that somebody who's failing in the community is really sick and needs extra help and they get it, that they might not do better. And so if somebody graduates from hospice, usually it's not a problem, yeah.
So a couple of things, I'm going to interject my own question here. So based on this question about estate planning, I just did this as I mentioned earlier. So the lawyer says to me, one of your options is to have two doctors agree, on basis, in terms of deciding whether you want, treatment under a circumstance where you're not able to speak for yourself and so forth as the standard. And given your presentation, understand that that's legal. That's the legal standard.
Right.
But I responded to him, I said, that's the worst possible recommendation I can imagine, is that, because I think doctors, any two random doctors, and in particular in this community, are likely not to give you a very good amount of attention to that question. So it raises for me the option, and given your conversation about legal standards and you responded quite appropriately that the job of the lawyer is to protect the client from damage or injury from a legal perspective. Seems like we're approaching this document with different assumptions depending upon whether you're a lawyer or whether you're using it. And I think that's pretty fundamental. So it seems like there may be some upstream remedies in terms of viewing the document as more than just a legal document, and being pretty explicit about that in terms of training lawyers as well as doctors and other health professionals. And then the earlier comment you made about is there a way to have a system, that could allow people to approach these issues earlier in the process. It seems to me that we, the Roundtable, ought to be challenging you, the experts, to really think about both the time dimension as well as the information requirements, given progression from being well and doing planning to having disease and getting more proximate to some of these decisions and procedures, right up to the point where you're facing some of these tough decisions. And it seems like there's a model or framework that needs some work, some good intellectual work, to suggest when it's appropriate to have which conversations, what kinds of issues and domains, and then make some proposals about a systems approach to handling these issues for something. So noodle on that. I don't know if you want to respond to my comment directly, but it seems like we need that sort of thinking. Maybe it exists and I'm not aware of it, so I apologize.
You're speaking about care planning, right? In terms of,
If I'm a patient now, do I segregate that? Is it just care planning that I'm concerned about? What are my concerns?
Yeah.
I think it starts right with talking to people and figuring out what their issues are.
Yeah.
When they're trying to think about the end of their life and medical issues, what are the whole range of it?
Well, and I agree with you, and I think, I'll just talk from the advanced care planning perspective. I think most of it is focused on end of life. And to be honest, a lot of our work is bringing it upstream. And we wrote a paper called Redefining the Planning in Advanced Care Planning, because I don't think it's only about CPR or mechanical ventilation. I think it's about helping people, even when they're healthy, learn how do you talk to your doctor, how do you identify what's important to you, how do you tell people what's important to you, and how do you translate that into the medical care that's right for you. That could be starting a blood pressure medication. That could be going in for an elective knee surgery, or that could be having, needing CPR or a serious surgery. So in my mind, I think the planning and advanced care planning is very much sort of starting even when you're healthy, sort of all the way through. And you might change that conversation, the things that you're talking about or thinking about changed based on your, clinical health and where you are in your life. But I do think it can start much earlier.
Can lawyers work with others?
I don't know if lawyers can work with others, but I will say that the elder law attorneys out there are pretty good. I used to, in my law school days, I was part of an elder law clinic. That was one of our clinical experiences. And that's where I learned a lot more about the counseling aspect of lawyering. And that's where I think we should be able to work with, wouldn't it be great for Rebecca and I to talk to people about their end-of-life issues, and she could really talk through all of the procedure, or not even end-of-life, but just to get to that point like she was suggesting. And she could talk with the patients, and I could come up with something that would clearly kind of convey that information. I think there is a synergy that's there, but we just, it's probably not feasible yet, but we can get it done at some point, I think. I think it's definitely possible.
Can I bring something up about that? Working right now with some people from UC Hastings School of Law, and there are all of these medical legal partnerships that are sort of springing up. And so lawyers coming into the clinic, and you can do those two things sort of at the same time.
That's an excellent point. So we've got Wilma, Lori, and back around to Bernie and then Cindy, okay? And we're coming to the end of our times. So Lori and then Wilma.
Hello, I'm Lori Hall. I'm from Eli Lilly and Company, a pharmaceutical company out of Indianapolis, Indiana. And my question has to do with, this is something my roundtable members hear me bring up often, is the concept of what gets measured gets managed. And often passion alone doesn't influence change. Sometimes it takes some nudging. So what we do know is, for example, health literacy was often around the fringes until the Affordable Care Act came, and it brought it to the center because patients were given the opportunity, through quality measures, being surveyed about their experience with their providers and with hospitals. Did your physician allow you to ask questions? Were you explained the risks and the benefits of this medication or side effects, that sort of thing? So do you ever see informed consents kind of coming into that realm where how they're written, at what level, in plain language, and perhaps attorneys writing those would be measured on that? Is that something even being thought of?
We are measured by judges. Seriously. And so that's where I was suggesting that if we could make some of those arguments in a legal context, and the judges, or at least one judge, buys that, that's our measurement. That is where we can get a lot of inroads. Now, in the kind of the larger healthcare organization construct, I think that can be done. In your Eli Lilly's or United Health Groups or whatever. I think some of that could be measured that way, but I don't know about with the from a clinical with the physician aspect if that could be measured. But it possibly could. We just have to, I think, put our heads together and see how we could measure that and actually get lawyers to buy into it.
Wilma?
Again, thank you so much. Great presentations. Chris, I just have a question for you, and I'm looking at the presentation from the Prezi, and thanks for using the Prezi appropriately. I'm looking at this, and I look at the consent form, and on some of the forms, I see witness, patient, responsible party. These are all the signatures, right? And then physician signature. And then on another form, I see patient, legal representative, and then witness signature. And then another one, I see patient signature, witness, physician signature. What is the significance of how this is going to be formatted and used? The reason I ask, Wilma Alvarado Little, language access advocate, Albany, New York. So if I'm interpreting on a unit, sometimes what happens is, depending on how this is laid out, the witness line, I as an interpreter am being asked to sign as a witness, which is inappropriate for me to do. So how can I present the information in a way that could be heard by the provider with whom I'm partnering with that patient? And does the presence or absence of any of these terms and combination of make a difference?
That depends on the state regulations. Some regulations require the witness signature, other states don't, depending on, it also depends on the type of treatment as well, with HIV or whatever, having their own regulations and different things. So a witness box is not going to hurt anything, and it could easily be put in there. It's more of a helpful scenario, even if it's not required to have somebody, and usually it's a family member that witnesses the signature, which again is somebody you could then, from a legal standpoint, somebody who could then attest to this person signing the consent form. So you will see that kind of as the default in there. And but from an interpreter standpoint, that's a really good question. I actually, every English-speaking country is ahead of the United States when it comes to plain language. And in doing some research on this, there is a colonoscopy form out there from Queensland in Australia that incorporates a box for cultural needs, and there's I think an initial or signature for the interpreter in there. So we certainly could work something like that into the form, like as just a again a legal documentation that occurred. But again, it's more the fact that it occurred that the patients care about more than the legal standpoint. But yeah, I think we can do that. We'll certainly meet those needs, and it has been done at least, if not in this country that I'm aware of, but in other countries. So, yeah.
Bernie.
Yes, I'm Bernie Rossoff, the North Shore LIJ Health System in New York and QHC Advisory Group. I'm also a gastroenterologist, so I look at the colonoscope from the other end. I took the opportunity while, after you were speaking, to open up the website of the American College of Gastroenterology, see what they have to say about the issue we are discussing, informed consent. And I was surprised to see that they actually had a full PowerPoint presentation utilizing a lot of the discussion points that we had today. But I was particularly impressed by the summary, and there were 3 bullet points that seemed to me to be important in this discussion. Number 1 was that shared decision-making is the key to obtaining legally effective informed consent, regardless of what consent form is used. So more focus on the shared decision-making between patient, family, and whoever, physician, gastroenterologist in the colonoscopy area, rather than a focus on the consent form. Number 2, in the state of Louisiana, where this comes from, there apparently have a advisory group, a expert advisory group that lists the risks, material risks, and that must be updated on a regular basis for the physicians to use. And lastly, the last comment, that current lists and shared decision-making are primary keys to maintaining constitutionally valid informed consent statute. So your thoughts?
My thoughts are, well, do I want to go back to first-year law school? Not really, but Louisiana is not like every other state because it comes from the French heritage, so they have more of a civil law system rather than a common law system. So, but the same principles are there, except for they're going to have a lot more regulations there that spell out the law, and not case law that's evolved since 1908 or whenever it was from Justice Cardozo. So they're going to have a lot more requirements in a civil-based system, as it is in Europe and some of the other non-common law-based systems outside the UK. But that makes sense. So if I was drafting a form for a Louisiana lawyer, I would comply with those risks and make sure those risks are put in there, just because I'm going to be in cahoots with what my state suggests. And so I like that. I think that is a good thing from an advocacy perspective too, because if there was an informed consent procedure in Louisiana that, where there was some litigation over that and the form didn't comply with those things, that would be a pretty solid argument under the reasonable physician standard that, hey, you didn't follow what this major body says. So that's where I think we as lawyers, as health lawyers, need to take that to the next level and make those arguments, and that might help the ripple effect in getting everybody else on board. So I do agree with you.
And then Cindy, you have the last comment before we take a break.
Thank you. Cindy Brock from the Agency for Healthcare Research and Quality. And my comment is for Rebecca. You know, your presentation, I thought, brought to light something which perhaps we hadn't given enough credence to. In the informed consent process, we talk a lot about the risks and how likely the risks are. But we don't talk a lot about how likely the benefits are. In other words, what is the likely outcome? And when we talk about the good things that could result, how likely is it that I'm going to achieve that? And so in your best case, worst case scenario, you had one slide which kind of showed two choices between surgery and palliative care and where the likelihood was in a visual way. And then on the next slide, you gave the two best scenarios and then said, which one sounds more like you? And so if that was what you were presenting, then I think you lost what was in that earlier slide of how likely it is. So could you tell us a little bit about whether or not you've actually done that process where not only you're eliciting their preferences, but their understanding of how likely the different outcomes are for their choices?
So for the presentation, I only did the best case. But if you actually look at Gretchen's paper, and I recommend that you do because I think it's laid out very well, they go over the best case, the worst case, and then the most likely. So, and it's interesting because I think in the way that I've sort of communicated with patients, especially sort of around difficult topics like end-of-life care and life-sustaining treatments and things, it's something that I sort of naturally did. And when Gretchen actually came to UCSF to give a presentation, and I was like, this is great, because I've been doing it, but she actually sort of laid it out. So I think that I do that a lot. And the one nice thing about her model is that, you know, the most likely for that person, it's not going to be the same for everyone, right? That thing's going to move up and down depending upon where somebody is in their own health. So I just think it's not the best model, maybe. It's not the model that everybody should use, but I find it to be a helpful framework. So just because we had limited time, I didn't go through all of the different things, but that's,
It's really showing that the series of trade-offs you're making.
Yeah.
So, thank you very much. If you were likely to overestimate the benefits and underestimate the harms as a doctor, would you put a little adjustment in those scalars?
Yeah, I think they're depending upon how much you're trying to coerce somebody, or maybe you have positive thinking,
Yeah.
that sort of could move, but you hope it's based on fact.
Thank you. This has been a terrific panel. I want you to join me in thanking both of them. Thank you so much. Really appreciate that. We'll be taking a break till 10 past the hour.